Hi there, my name is Lisa Ackerman. I want to welcome you, and I am just so excited today. In the news, there's so much information on autism, specifically on prevalence. And our goal is to interview expert resources and share facts. We want our community to understand the methodology and the rate of autism, its dramatic increase. And today with me, I have the great pleasure, and I want to thank Dr. Walter Zahorodny for joining me today. And Walter, you are the principal investigator of the New Jersey CDC study and data, and the associate professor of research from Rutgers University. So I'm grateful. Thank you for joining me today.
Yeah, thanks a lot for inviting me, Lisa. I really relish the opportunity. Thank you.
Well, good. And we have a lot to cover. And I pared down 50 questions to 18, but I have so many questions. And really, my whole goal is to understand more. And really, if you don't mind sharing a little bit more about yourself and how you got involved in autism prevalence.
Yeah, way back at the end of the 1990s, I was already part of the New Jersey Medical School, and my colleagues in the pediatrics department started coming to me and saying, would you consult on some new patients? Because it seems like we have patients with autism coming more frequently. I'm a developmental clinical psychologist. And so I said, okay, anytime. And how many could there be? Uh, in graduate school, I learned about autism, but it was understood and described as a very rare disorder. But in any event, many kids started to come forward with their families. And yes, they all had autism and some other medical condition or problem. And it seemed very unusual. And it seemed that these children were very complicated in their health needs and their learning needs. And so we tried to form like an autism center or autism group. Um, Along the way, we started to hear about CDC going to Toms River, New Jersey. Some parents had brought the attention of a congressman to their community where it seemed like there were more children with autism than expected. And lo and behold, the CDC came with a community study and they found, yes, pretty high rate of autism, 6.7 per thousand. Like 3 times greater than what was expected. Expected was 2 per thousand. And so they said, wow, that's kind of high, not really sure why. But we don't understand autism and it seems to be increasing in many places. So they established a multi-state network called ADDM, Autism and Developmental Disabilities Monitoring Network. And it was like a competition for investigators to join. If you wanted to join, you had to represent your state health department and promise to do very careful surveillance in your region. And in New Jersey, we said, wow, this is like great. Well, maybe we can understand what's happening by doing this investigation with the CDC. And so my colleague Frank Esposito and I applied. We were, I guess, in the right place at the right time. And they wanted to look at New Jersey because Brick Township is in Ocean County. And so we started doing surveillance in 2000, 2001. We had to get a lot started. Nobody had tried to do surveillance of a childhood developmental or behavioral disorder. And it takes a lot if you're going to do this in a way that is comprehensive and gets to every child, you have to have agreements and understandings with all the school districts and all the major health providers. And we built a network. It was kind of impressive because I really hadn't understood to what extent people were supportive of the idea of that. But indeed, I guess in New Jersey, autism was already becoming an issue even before that. And so we got off the ground with the CDC. We don't do surveillance in the whole state. We cover 4 counties. Essex, Union, Hudson are in the northeast part of the state. They're right opposite New York City, across the river. And Ocean County, that's the 4th county. We added that because of Brick Township. Let's say Brick Township could have been a cluster. We could only learn that if we knew what the prevalence of autism was throughout the county. And so we did that 2000, 2002, 2006, 8, 10, 12, 14, 16. Same method, same definition of autism based on the current diagnostic criteria from the APA. We had great access to health and education centers. The school districts, we had a lot of them, like 76 different districts in New Jersey. So the level of support was key. And I guess we were at some point seen as professional and safe. We never exposed anybody's information. There were no accidents. And everybody understood that we took a lot of pains to be very accurate and complete and to maintain confidentiality. It's really an
Wow.
act of trust, I think, to get districts and hospitals to trust people to look at information because it could be easily abused. But it was the key because, interestingly enough, when we got the agreement with CDC, I thought it would be pretty easy to do what they wanted because I thought all we'd have to do is look up different children's diagnostic codes in some big database. And the ones that were diagnosed with autism, we would just count them and figure out how many kids there were in the whole population, and that would be it. But in reality, it was a very comprehensive method that the CDC established where we took a lot of information from many, many evaluations over time. And that information went to a second phase, which was analysis by experts, people who were familiar with autism and who followed pretty strict guidelines as to scoring and determining which of these children really had autism. And the process works great. In a state like New Jersey, where there's a pretty expensive, well-funded, capable education system, there's a lot of records and evaluations. And in a region like the New York, New Jersey metropolitan region, where there are medical and developmental professionals, you get to see doctors who diagnose autism and figure out how to help people. And so we had access to all of that. And so that's what we've been doing every 2 years over the last 16 years. Takes a while to get all that information and to get it analyzed. To be honest with you, I thought it would be a 4 or 5 year project because I said, once we do this 2 or 3 times, we'll find that autism is at X percent. And then again, it'll be at X percent the next time and at X percent the same time, because developmental disabilities don't increase over time. Nobody had a clear picture of that from other problems. But somehow, each time we looked, the prevalence increased. And it was surprising because the methodology was explicitly developed to help us find all the true cases and minimize the non-cases or the false cases. So using the best method in a place with the best data, we kept showing that the increase was continuous, basically continuous over the entire time period.
Wow. And your work is so important. So thank you. If I could, I want to ask a question about the March 2020 data, the prevalence rate. Bring everyone up to speed. What were the findings from March 2020?
The most recent findings, those would be for the 2016 study year. The range of states, we had 11 states in the ADDM network. Some states recorded autism prevalence as low as 13%, like Colorado and Missouri, and other states as high as New Jersey, 31 per thousand. So if you make an average, that would say that 18.5 children per thousand, or 1.8% children across the network have autism. And that would mean an increase of about 175 in some states to 200% since they started doing autism surveillance in 2000. The other findings that I think are important from that cycle are that even after lots and lots of autism awareness and information, we're still finding that the age of first evaluation, first professional evaluation, has not changed in 16 years. And the age of autism diagnosis hasn't changed in 16 years. That's a big surprise and a big disappointment.
Yes.
It means that children are still not being identified early enough with autism. And in some states, not all states, we also identified that there's a race-based disparity in autism identification.
Right.
In some states, if you're a Black or Hispanic child with autism, you don't get identified as frequently. If you are identified, you're identified later. And if you're identified later, you don't get the benefit of early intervention program,
Yes.
and that's a big disadvantage.
So how young can we diagnose autism? I don't mean to dive in and cut you off. I just want context. I mean,
Yeah.
reliably.
Most people would say that the majority of children can be diagnosed between 18 and 24 months. Not every child with autism can be, because there are varieties of impairment and complication in autism. But definitely 18 and 24 months is the golden period during which we can identify maybe 70, 80% of all the cases.
That's so important. And I agree with you. We should be doing better. It's something, even a simple MChat, with a pediatrician should be able to be administered and referred. So I really, there's so much to get to. Why is ADDM only based on 11 states?
Yeah, so I guess all the funding comes from the CDC, and the CDC decides how much to spend on autism surveillance. I guess there's a limited amount of money. And when they try to figure out how to spend the money or what states to involve in surveillance, they use a kind of a standard academic process by which you write a grant application, and the ones that are best written or have the best information or likelihood of success are funded. When ADDM started, they funded 6 sites. More recently, they expanded to 14 and now to 11. The 11 states, they're participating because there are investigators in those states who wanted to do surveillance, and they could secure some basic cooperation from their health or education departments. These states are not representative necessarily, but it's a very large population that's covered by ADDM.
Got it. What's the methodology used for the prevalence survey, and has that changed?
From the beginning through 2016, the methodology was consistent, and I would call it active multiple source case finding. That means you're not just looking for cases that have had a diagnosis of autism or were classified for autism services in school. You're looking for children who have autism through the professional evaluations that they've had until age 8. All the ADDM studies, almost all the ADDM studies, focus on children at age 8. And so we're trying to identify through the review of available records which children had the pattern for autism as described by the by the APA manual, by the current diagnostic criteria.
And so let me ask, do you see there's a larger increase in autism over other disabilities?
Yeah, maybe I'm not an expert epidemiologist, but I have read the literature, and there's no other disability that has increased as significantly as autism. The only one that comes close is attention deficit hyperactivity disorder. From my look at the literature, it looks like that has increased possibly 40 to 50% in the last 2 decades, while autism has increased I would say 200% in that same period.
Wow.
Those two disabilities have definitely increased. Interestingly, I learned that most have stayed the same, like vision impairment, hearing impairment, but some disabilities due to cerebral palsy, CP, have actually decreased. So there is some change in these disorders or disabilities over time.
So the media regularly says it's a better diagnosis or broadening the criteria. Why do you think that is if you're stating that there is a true increase? Why do you think they say those things?
I think, well, hard to understand all the social psychology and communication psychology behind what message prevails. Uh, I guess I'm not as sophisticated a psychologist as I thought, because I would have thought that evidence usually in the long run trumps good public relations, but maybe my time frame isn't right. Maybe it takes more than 20 years to get the true information out. Um,
Oh,
there is better awareness of autism, no doubt. If
right.
you look at the number of publications, media presentations before and now, it's much greater. You hear about autism in multiple venues all the time. And more professionals have been trained to understand autism, and more teachers come into contact with
Mhm.
autistic children. And so definitely the knowledge of autism has improved. But it's not sufficient to say that awareness is improved when indicators of awareness haven't really improved. Some indicators that haven't improved are the ones I just mentioned: age of first evaluation,
Right.
age of autism diagnosis. If if everything was a matter of better awareness, we would have seen some shifts in those indicators, but we don't see
Yes.
that. And the other thing is we see that the upward increase in autism goes across all subgroups. It's not just that we saw it increase among white children or Asian children or children from one region or another, or from one socioeconomic group or whatever. Autism has increased across every subgroup and category we can think of. So a broad increase like that and consistent over a long period of time does not represent the pattern you would expect with better awareness. The better awareness pattern, in my opinion, occurs when you get to a new definition, like the start of DSM-4 criteria. And then you see for 4 or 5 years, people pick up and diagnose more because now they're aware of a new standard. And then it tapers off and plateaus. But in reality, we've never seen the plateau in autism rates that would be expected if better awareness was the factor. There's a big difference in, is the prevalence 1% or 3%?
Mhm.
And you would be able to see the reasons for that. I haven't also, if evidence is to be a good guide, I haven't seen many good quality studies in which they quantify the effect of better awareness, whatever that could be. There was a good paper from Kim Van Arden Braun, where she looked at CDC data from Atlanta on autism prevalence and intellectual disability. She didn't see what you would expect, the better awareness pattern, which would be shifting prevalence between autism and intellectual disability kids. So it's a strangely successful culture meme that autism prevalence increase is a function of better awareness. In my real world, people don't develop programs in anticipation of autism or some problem. They do it after the fact.
Right.
And somehow people have confused a better awareness with true increase or lack of true increase. Every indicator of autism prevalence, and I would consider our evidence to be the best, but even other types of trends all show the same phenomenon, increasing by 100 to 200% in a 2-decade period.
Wow. And I'm so grateful for your work, truly. And in 2013, they did a census of autism in Minneapolis, and it came up with 1 in 48 rate. Will there ever be a census like that in the United States?
I may not, I'm not sure I know how you mean census, but I do know that study, and I know, so if you're asking, can we understand or do autism prevalence at a smaller level? Can we find out what it is at the county or the town level?
Mhm.
The answer is definitely yes. And can it have some valid uses or informational reasons or purpose? Yes. Um, so they did in Minneapolis what we do in every cycle. They looked for cases through health and education records. And they found an interesting pattern. And I guess it was just, in a way, inadvertently also interesting because they show that you could look at local findings. What is autism like in Minneapolis? And now they're surveying a wider area and they could make comparisons.
Mhm.
Is the rate the same in urban or in rural areas or in some other way? Um, so it is possible to break down or to analyze the atom information in smaller areas. And we did start doing that recently in New Jersey. And we have a paper that's already submitted, which will look at autism prevalence at the county and the school district or municipal level. And that will show us some interesting things about the scope of autism and differences in autism prevalence. So yes, yes, Minneapolis was a good precedent because they responded to a need, much like people responded to a need from Tom's River. It's fascinating that both in Tom's River and in Minneapolis, the epidemiology or the experts followed what parents had observed. It wasn't that the system detected anything, it's that the parents came forward and said, hey, looks like there's more autism than you would figure.
Right.
So I accept the pattern. I don't fight the wave. I recognize that it's there. And I would be shocked if you were to speak with people in the educational public school system or in the developmental health systems and say, do you think the prevalence of autism is true or actual, or is it that we have better awareness and knowledge of autism? The people working with affected individuals, children with autism, adolescents with autism are not doubtful that this is a true increase. It's only when you get higher and higher into the academic stratosphere where people can say a theoretical possibility, better awareness has made a 200% increase in a pretty striking childhood disability.
Yeah.
Autism is a real thing. It's not like a subtle thing where, I don't make good eye contact or I'm not interested in your story, just in my story. It's in children, it's very observable and it has very big consequences. And anybody in the school system will tell you now there are whole classes of children who need special assistance for autism.
Right.
In the past, yes, even 10 years ago, the 1 or 2 occasional children with autism could be sent to a special school in the region or in the district or something like that.
Yeah. It's definitely, we see the same thing. And God, I'm so grateful for your work. So what version in the last March 2020 prevalence study, what version of the DSM was used predominantly?
We used both. Interestingly enough, we did a lot of extra work. And in that year, every case was figured by DSM-4 criteria and then independently by DSM-5 criteria. So we generated estimates for both systems.
Oh,
It's in the report, though it obviously doesn't take up a large, it doesn't have a large footprint in the report. In summary, the DSM-4 criteria are slightly more sensitive to autism, but the difference didn't amount to a big difference. 1,036 individuals identified by DSM-5, 1,055 by DSM-4 criteria. So not a big difference.
right, right.
Very interesting, however, we also do surveillance at age 4, and there the difference was pretty significant. The shifting from DSM-4 to DSM-5 allowed us to find far fewer kids under the DSM-5 criteria.
Wow. Wow.
The DSM-5 criteria are slightly narrower. I think everybody would acknowledge that, but they're also specific in a way that makes it sort of unlikely that children under the age of 4 will satisfy the criteria. There are just
Interesting.
situations where you can't observe the child in question with other peers or have many occasions for understanding whether they're interested in having a friend.
Got
So
it.
at the 8-year-old level, maybe the effect of shifting is minimal, but at the 4-year-old level, no way the DSM-5 criteria are sensitive enough.
So when do you think DSM-5 will play a bigger role and be the predominant tool?
Definitely everybody is using DSM-5 criteria now in the New Jersey, New York metropolitan area. They've all shifted, and all professionals are intelligent and adaptable. And when you tell them the definition is ABC, they show you the evidence for ABC in their reports. That's the
Right.
goal. If you shift the definition to say, now the definition is BCD, they shift as well. Autism is not going to decline in real prevalence because the disorder is there and it's not going to go away. People will subtly shift, and even it'll probably take them a little more time, unfortunately, to get to the diagnostic conclusion.
Yeah.
But the conclusion of 5 and 4 is the same. Children with autism get identified when they see a professional who's experienced. And that's not shifting much. The definitional change is minor. And I'm a clinician. I still see patients. There's the patients which would have been seen and diagnosed with autism in 1988, 1990 are exactly the same as the individuals diagnosed today.
That's a good
Unfortunately,
point.
there's a lot more of them.
Yeah.
It's like
Thank
3 or
you.
4 times as many as there used to be.
Well,
A
that's
long
why your
time
work is
ago,
so important.
long time
Sorry.
ago. Yeah, more questions.
Well, the one that kind of leads to functioning level, and again, I want to say this in the right way, is the functioning level changing in the prevalence studies. So do we have more children with more needs versus more children who are just barely being diagnosed?
Definitely more children with autism and more children with more needs. That's incontrovertible. That would be the first thing that I would say. This is a true increase and an important increase. Also, however, since we're able to do comprehensive surveillance, I see that the increase of children who are also intellectually disabled has doubled, while the individuals who have autism but not intellectual disability has quadrupled. So both groups are increasing. And if you tell me doubling of autism plus intellectual disability is a problem, I'd say, yeah, definitely, it's a problem. A very compelling, important thing to do something about or to prepare for. But the other phenomenon is that more children than before are also showing uh, better intellectual functioning. Maybe this is one of the findings of the network which is most solid. When we started doing something, when we started doing surveillance, the typical thing was to read in the current journals or reports, autism affects 70% of children with autism also have intellectual disability. That is definitely not true. It never was true, probably, but the number of children with significant intellectual disability is very great, but it's not that high, never was that high. And we are seeing increases of children who have average functioning. What we're not seeing an increase in are those kind of media autism examples of like a savant or a genius or a very like expert person who just doesn't have social ability.
Mhm.
That pattern, uh, that pattern of individual who has IQ above average, but signs of autism, that is no more than 3 or 4% of all the individuals with autism.
Wow. Wow.
So
And that's the Aspergers, if you will, the old label of Aspergers for
correct, yes.
clarity. Okay.
Yeah. The old model where you have good intellectual ability or better, and you have good language development early
Mhm.
before age 3, and that your impairment is mainly in social awareness or social empathy.
Mhm.
That's the rather small number of all the affected people with autism. And it's stable. The proportion hasn't increased. It's not like we're picking up on these mm, borderline individuals or quirky individuals.
Right.
It's not like we've redefined the concept to include everybody who's slightly atypical. Autism is a real disorder, a real disability. It's really increased. The number of people who have high functioning, they're important. I would be interested in knowing them and working with them.
Of
Maybe
course.
they're not even, maybe they don't need anything, but definitely the vast majority of people on the spectrum have very complicated, significant needs.
And that
And
kind of, again, I don't mean to, I'm sorry, had a lot of coffee. So just kind of follow up on that. Could a possible strategy, and I know I'm throwing you a question we don't have control over, but would a possible strategy maybe be to reinstitute the label of Asperger's? Because it is a better definition versus autism 1, 2, and 3 in DSM-5. So Asperger's could hypothetically get an acceptance as a strategy versus the disability, what you said, the 98% in this other pool. We apply more strategies, tools, resources to provide aid and support. I mean, what are your thoughts just on that?
I would say that definitely the more specific we could be in identifying what the person does or can't do or needs help with, the better we are. Some people may need very little or just some support or assistance of a minor level at a minor level, but others, if you understand their scope and functions, you would say, well, the best thing would be to offer strategically uh, based on the person's needs or the person's limitations. I have no problem being more detailed. And the more detailed and kind of careful we are, the better we are also going to be able to accept those individuals. If acceptance comes from understanding sometimes, if we understand there are limitations and there are limitations which cause impairment, they're going to require different sets of strategies to to assist with.
Agreed. And for those folks who need more help, gosh, it's our obligation and duty to really support them and give them the help they need.
Right.
Thank you. God, I wish we had the ability to make that change and provide more clarity. Do you think insurance companies could help in giving us more data and sharing autism prevalence across the United States.
Yeah, I guess in the long run, I know insurance is a business and they have to make money, but I think based on what I understand of autism and interventions, if you can identify early and provide the right interventions, ultimately you are helping the person be at their maximum, at their most productive. And that's the standard that we're aiming for. If you wait or you don't provide a necessary treatment, you're just helping incapacitate a person. People who are unable to participate in work and other social engagements, they're like a pool of unknown resources or unmatched resources. So I know it seems like contrary to making money, but I would say provide effective early diagnostic, early detection, make it feasible for every family practitioner and doctor to do that at 18, 24, and 30 months. Make screening in the preschool period also available, because there will be children with more capacity, more social capacity, or more intellectual capacity who don't get picked up before they get to kindergarten or first grade. There should be an effective screening approach to identify those kids and get them the right interventions. There is no downside to the interventions that are provided. It's not like we're giving a dangerous agent or a chemical. These are things which relate to behavior, social exchange, and language development. So what is the downside to early detection, early intervention? And maybe I think there will be an outcome in the long run that even makes sense to the insurance company adjuster, who's mainly concerned with is it costing money or not costing money. In the long run, it costs a lot more money to avoid key challenges.
Right,
So
right.
I wish they could do that, and I wish there could be consistency. There's an IDEA law which mandates services before 36 months, before and also afterwards. Sometimes they're well administered, but there's such a range from state to state.
Totally.
The uptake is even very diverse or very, very heterogeneous. In some states, um, shocking, I guess, under involvement of people or under use of the system.
Right.
So, and these are federally mandated programs. So interventions have to start as early as possible. Insurance companies have to provide their fair share. And the programs, there should be more uniformity. This is all like done locally, and California is different from New Jersey and different from Montana or Idaho. But the expectations of what we would want for children to have a good development is not so radically different from state to state. While children should be stimulated in language and thinking and understanding and playing. And if they have a disability, that's not an excuse for not providing those things.
Right. And the landmark RAND study, they said for every dollar invested, you have over $17 of return in early intervention. To me, it seems like better than anything on Wall Street to invest in our younger population. My goodness. So I love that point. Appreciate that. So when's the next ADDM date? When do you expect, and what do you think is going to transpire next?
So the next ADDM cycle is for 2018. That would be kids born in 2010. We have 11 states. However, the network has been shrunken. The states are all reduced in their the region they survey. In New Jersey, we survey 2 counties instead of 4 counties. And more importantly, all the sites have shifted to a different definition or methodology of who has autism. We used to do active case finding. That means finding all the children in an area who have autism based on the information we can get. Now we're only going to be recording children who have an autism diagnosis. Children with autism, not every child with autism is diagnosed by age 8. Very consistently in New Jersey, we find that 1 in 5 kids with autism has no autism diagnosis, though they have autism. So shift to a new method in a smaller region means that the new findings will be less reliable, less complete, and will underestimate autism in some states, like New Jersey, probably by 20%. It's unfortunate too to shift to a new method because it makes like all the work that's been accomplished by the network so far kind of null. When you shift to a methodology that's totally different and smaller, you can't say anything about what happened before you started doing it that way. So we have a scenario from 2000 to 2016 of autism increasing according to a kind of method and a definition. And now it's going to be like starting all over again. We have a different definition and a different method. And you're not going to be able, if you're statistically or epidemiologically oriented, to make easy sense of what's happened it's like switching from a different gauge of certainty. So
that seems like a total shame. Why is that? Do you know?
So my impression is that the methodology was great. Some states don't have the same access or the same quality data. And it takes a lot of resources to do what we're doing. And it takes a lot of time. So people say, wow, so many resources, so much time. So probably somebody made a strategic decision saying, look, if you want there to be an ADDM network or an autism surveillance network, it should do something faster and it should cost less money. And so the way to save money and to do something that happens faster is to shift to something that doesn't require anything really interpretive or analytical. What's recorded in the record, whether it's true or not, will be a signal of autism. And so you're going to have a less accurate estimate because you'll never find the ones who are not diagnosed. And the information that we get out of the system is going to be far smaller. So maybe I don't know why, I don't understand really why, when autism prevalence has been going up so consistently, why would people take the cheaper alternative or the less reliable alternative? It seems like, don't you want to know? Don't you want to know what the best estimate is instead of maybe like an average or a mediocre estimate? And don't you want to know at what point something shifts? Or don't you want to link your careful information with many elements of information about your subjects to some other database that could maybe show a risk factor? It seems in a way kind of incredible that you would want to do half a system or a step down system from what existed before you really understand the problem.
Right.
I'm pretty sure once you understand the problem, i.e. what are the risk factors or the causes, maybe you don't need to do surveillance every year or every 2 years because you're going to understand something fundamental and be able to take action on it. But we're not at that point yet.
Yeah, it seems like a big step back, and
yeah,
I'm
to be
super
honest with
disappointed.
you, I think it's a cost thing. And don't ask me why in this day and age when autism is important, the major public health authority wants to know less about it. It doesn't make as much sense as you would want.
I'm editing my thoughts. I'm editing my thoughts. It just doesn't make sense to me. And I hope if there's an avenue that the TACA community could assist in saying, hey, we'd really like to stay with the same methodology so we can accurately, compare each ADDM report
Right.
to each ADDM report. You let us know. I'd
Right.
love to know that. God, I could spend 2 hours just on that, but I have 2 more questions, and thank you for bearing with me. The COVID-19 has thrown some wrinkles in, and our support network is observing from data and calls coming in that some families are going from 3 to 6 months, maybe 9 months at the latest for an assessment of autism, now 18, 24 months. And it's increasing rapidly for anyone with Medi-Cal or Medicare to get an assessment in this time. How long will that affect until we see that effect in the future numbers?
Yeah, I'm afraid that we're going to see this into 2022. There's really no shortcut, as I see it, no rapid way to cut through the individuals who are waiting to be evaluated. People have experimented with some virtual approaches which involve telecommunications and video monitoring. I can understand that. Those are creative solutions to a difficult problem. But ultimately, there are a limited number of professionals who diagnose autism who are experienced. And now there's a double or triple backlog on the waiting list.
Right.
So it's going to take a while. And unfortunately, I don't see how the diagnosis is important, but the interventions are missing in the meantime often too. If I'm waiting to get a diagnosis and diagnosis is related to getting higher quality or more comprehensive educational services, you're losing more than the diagnostic label.
That missed opportunity to intervene
Yeah,
and support. Yeah.
yeah.
Oh, I guess my last question's a biggie for me. I wish I had unlimited resources. What would you recommend as a next step, given all of the data and all of the situation that we've come from in this autism ADDM survey? What would you recommend as a next step if you had control?
If I had control, next step would be to formulate good plans or adequate plans for adults with autism, because all the kids are heading toward adulthood, adolescence, and adulthood. In my opinion, the current structure of the educational system for children with autism is way better than the structure of support and services for adults. There's a gulf between what was expected or could be delivered or was delivered in the education environment versus what will happen in the adult developmental disability range. There must be gigantic issues related to residential support services, occupational and professional education, all the things that could help somebody become more independent, more capable, more satisfied in their life. If autism prevalence has been increasing like a wave, I hate to think that what the crest of the wave means for all the people who are going to be waiting there for that to happen.
Wow.
So adult care, adult services, early detection, because early detection might make a difference for the long run, and early detection beyond the toddler period into the preschool period. Maybe some preparation for physicians, a new type of practice that is familiar with people who have autism as adults, but is not really like an internal medicine or a psychiatry practice, but something that combines elements from many different practices based on the needs of the individual.
Oh, I
think
wish we could give you those resources to help us define what that would be and how it could be of help to so many adults.
I'm kind of impressed by the extent to which I've seen like academic centers develop very kind of comprehensive, sophisticated programs for children and sometimes for adolescents, but yet I don't see the same, I almost don't see, like, I almost don't see the foundation for that among, for the adult services and the adult care issues.
Well, maybe together we can make those changes and help move things forward. Like I said, it's a wish. And, first we have to identify it as an area of need and then get active on that. So, but, Walter, Dr. Zahorodny, I am incredibly grateful for your work. I can't thank you enough. I know all the families at TACA, the 75,000 we serve, were behind me. They would all want to say thank you for your consistent quality and driven efforts to really just shine a light on there is an issue here, people. We have a heavy increase in a once rare disability, is now increasing more rapidly than ever before. And I, from the bottom of my heart, very grateful. Hopefully we get to see you again. When you have your papers that you're working on published, we'd love to have you back and talk about those. So, but thank you for your efforts, and I just know you're making a big difference.
Yeah, thank you so much for your attention. Thank you.
Thank you.